All right, so you're going to be operating mostly, right?
Okay.
You got it right? You got it right?
Yeah, got it.
Okay, got it. So I started the meeting, whatever. People might start joining in.
Okay.
It's switched off the
Good morning.
Yeah. Hey, Dr. Wilson, how you doing?
Good, thanks. How are you today?
I'm pretty good. I'm pretty good. So we'll be starting the conference in about 15 minutes.
Okay.
Yeah.
Hi, Dr.
Gotcha.
Wilson.
This is Dr. Oye here.
Yeah. Hi, Dr. Wilson.
Yes, sir. Good morning. It's good to see you.
Yeah, good to see you. Thanks. Appreciate it.
My pleasure. I'm looking forward to it.
Excellent. Thank you.
All right.
Okay, good deal.
Hello, Dr. Ryan joining.
Hi, everyone. We're just going to be starting at 9. So just wanted to let everybody know. Eastern Standard Time.
Yeah, so many files, I have to get more. Yeah, I didn't even get one from yesterday's. I have one for the in hope to, yeah. This will still get to update the address so they know that. Nope. And by myself, yeah. Yep. But Rita needs to know, otherwise. Yeah, you gotta reply to it and put the non-is on board. Where did I find my schedule? I think, oh, there you go. Okay. 4 West board still not working. Recall the plan to take it. They didn't have it. Which one is still working? The 4 West one. The what? Oh yeah. I tried to update it. It's not working. Still, it's been like the whole. She just called last night. Okay. And got a new ticket number, so I put it in the safety huddle. Awesome. Yeah, because I tried again this morning. Yeah, so it's still not updating. Okay, I'll just do it. I guess they didn't have the last ticket number or something. Oh, Randy didn't do it? No, they had it, and they had the number, but for some reason, they said, oh, we never. Got it? Never got that one, so I guess they fixed it already, and then it happened again. So I don't know if they thought that they fixed it. I don't know what happened. Yeah. So that's probably leaking to the town. Correct. All right, have a good day, Rowe. Thank you. You too have a nice day off. 02724.
Start the video.
Good morning, folks. Good morning.
Good morning.
Good
Can you
morning.
hear me?
Yes, we
Yes.
can.
Excellent. All right. Hi, Adi. How are you?
Good. It's nice to see you.
Very good.
Good morning, Dr. Oye.
Good morning, Dr. Kashyap. How are you, sir? Thanks for joining us.
Thank you.
Dr. Rowe, you already up already. You should be sleeping, dog. Thank you so much. Thank you so much.
No problem, no problem.
Very well, excellent. You look handsome. In early times in California still. Wow. Wow.
It's surgeon time. Surgeon time is any time.
That's right. That's right. Very well. Thank you. All right, let's get started for interest of time so we can all get back to our busy schedules for Saturday. Thank you very much and welcome to our 2023 inaugural ground rounds for the year. We're dedicating the program to physicians and healthcare providers worldwide. And we believe that interesting cases should be shared and with our colleagues when feasible. The global ground rounds will be an avenue to promote such collaborations and we encourage our young and future physicians to participate in these programs now and beyond. The value of information exchange can be immense for colleagues who practice under challenging conditions in medical underserved rural or urban hospitals. And we believe that we can also learn from our experience here in the United States and share those experiences with others. I would like to thank the participating physicians and young doctors from Dr. Ugoji in Nigeria, Dr. Vincet Rowe in California, Dr. Kashyap here in West Virginia, Dr. Sangodeyi in West Virginia. And we would like to welcome you all to the program. We'll have a couple of young physicians in training that will present some exciting cases, and we'll look forward to their presentations. Without further ado, let's get started. If we have Dr. Sangodeyi on, we can get him started. If not, we'll move on to the next speaker.
He's still going to join.
Is it joining?
He hasn't joined.
Okay, all right. So let's start up with one of our young physicians. Let him get started while we get Dr. Sangodeyi ready. First presenter this morning is student Dr. Zachary Rhoades. As a third-year medical student who's currently rotating with me in vascular and vascular surgery, and will present an interesting case. We'll look forward to seeing what he has to present. Thank you.
Can you screen share? Yeah. Thank you, Dr. Oye. My name is student Dr. Zachary Rhoades. I'm a third-year medical student at LMU DCOM, and I've been rotating with Dr. Oye. I'm going to be presenting a case today on arterial embolectomy and atherectomy using Rhoades and angiojet tools. So patient was a 56-year-old male, history of peripheral vascular disease. He had an acute worsening resulting in his left lower extremity pain and purple discoloration per his description. Past medical history is peripheral vascular disease, hypertension, hyperlipidemia, and recurrent thromboses. Surgical history, he's had a fem-fem bypass, bilateral iliac artery stenting, and a prior left femoral artery stenting, and he does not currently use tobacco or alcohol. Allergies, he is anaphylactic to procaine, he has a rash to penicillin, and nausea to nitrofurantoin. Medications that are pertinent and vascularly related, aspirin, cilostazol, atorvastatin, and clopidogrel currently. On review of systems prior to the operation, he had left lower extremity pain and purple discoloration, but no nausea, vomiting, fever, shortness of breath, palpitations, trauma, hemoptysis, no signs of a thrombosis that dislodged and became a PE or any other problems in that sort. Physical exam, he just has the left lower extremity pain, and there was a darkening and discoloration. And there was decreased dorsalis pedis and posterior tibial pulses on the left lower extremity physical exam. Procedure we performed, aortobifemoral arteriogram, and then angiojet embolectomy in the left with TPA, left femoral popliteal artery atherectomy via Rhoades, and then we placed a balloon stent in the left SFA. So what Rhoades is a machine. It has a bevel tip that rotates between 40,000 and 60,000 RPMs, depending on what size sheath you're able to use. What it does is the vortex, it breaks up the rotating tip, breaks up any atherosclerosis plaques around, and then it creates a negative pressure from the spinning, and the negative pressure allows for suction and removal of the dislodged debris from the artery, allowing for recannulation and opening up of that artery. What angiojet is, angiojet was for the thromboses. So it provides a pressurized saline in a retrograde direction from the tip, again, creating a negative pressure suction vacuum, which pulls the thromboses in, and then that high pressure saline is able to break it up into smaller pieces and allow for suction removal as well. And then to open up anything that's any vasculature that has been thrombosed. Here's some imaging for the pre-atherectomy. You can see that on the left, this SFA has occlusion and stenosis, and then the popliteal right on the right is occluded as well. And then here's some pictures. The SFA, again, poor flow through the old stent and things, and then the with some subtraction, again, you can see a little better of the occlusions and stenosis that's present. Post therapy, we can see much greater flow coming through down the SFA compared to the prior image. You can see much wider bifurcation and greater flows allowed through. Again, that region where we saw that there wasn't much flow through there, much greater flow, much wider. The therapy really worked beautifully and opened up that SFA. And then the popliteal, again, also just a beautiful result using that combination therapy and then placing a stent as well to just make sure that it stays open and hopefully prevent future thromboses and future stenosis from occurring. Status post-op, left lower extremity acute and subacute ischemia, peripheral vascular disease, pain in the limb, and then there was, as you saw, the occlusion of the left SFA, popliteal, posterior tibial, and peroneal arteries, which we were able to treat with the Rhoades and angiojet. Post-op, no review system showed no pain. There was no discoloration, and all other systems were negative. Exactly the outcome we were really looking for here with this therapy. Physical exam, the left lower extremity pulses were present with via palpation, and with ABI Doppler, we were able to find the posterior tibial and dorsalis pedis were much stronger, and there was no edema, no discoloration, and no calf tenderness, hopefully showing that we didn't dislodge a thrombus or create a new DVT. Discharge medications, Plavix, aspirin, Eliquis, and Pleadol. Referral to hematology for these recurrent thromboses to kind of figure out what's been causing them, and then follow up in office 2 weeks for removal of sutures and to ensure that the therapy the stents were still patent and we still had distal pulses and there was no recurrence of symptoms. Implications. So The incidence of peripheral artery thrombosis is 4.3% for the HA, and 77% of AV grafts develop stenosis or thrombosis within the first year per up to date. These therapies, angiojet and Rhoades, you can help prevent more invasive procedures like bypasses, kneading, and it can help endovascularly really help treat these problems with a minimally invasive approach with, as you can see, beautiful results without having to put new bypasses in or having to create new stents. Obviously, we did put a new stent in, but these therapies really are minimally invasive and really had beautiful results for the patients and are hopefully the direction that endovascular treatments can be moving forward to, because that 77% is just extremely high. And if you're able to go in endovascularly, clear it out, it would be extremely helpful. And these are my sources. Thank you very much.
Thank you, Dr. Bell.
Can you stop?
Thank you. Any immediate questions now? If not, we'll divert the questions to a later time after all the presenters have presented. But if you have an immediate question for Dr. Rhoades, please ask.
Okay, I do have a questions for Dr. Oye and the other doctor.
Yes.
Recently, I've noticed that the vascular surgeon and the cardiologist, they use a combination of anticoagulation. In this particular patient, in your post-op discharge medication, you gave him or her 4 anticoagulation: Eliquis, Plavix, aspirin, and Pletra. Why do you guys do that? I mean, do you really? I mean, I know they all have different mechanism of action. Is there any real reason why you have to give 4 anticoagulation for this patient?
This particular patient has had a long-standing history of thrombotic events, and he started about 10 years ago when he initially had what was an aortic, we had fem bypass and subsequently thrombosed, and was converted to bilateral iliac angioplasty and stenting. Through it all, then subsequently had another thrombosis of the left fem pop. Then again, it's like the 4th or 5th time it's thrombosed. Even though those medications were listed, the more he went home with Plavix and Eliquis. Eliquis was added more recently because of more recent thrombosis within a shorter period of time. I think less than 4 weeks. So yes, I typically would put them on Phlebectomy and aspirin. If I don't stent them, if I stent them, I really put them on Plavix and aspirin. Occasionally, once they have recurrent thrombosis issues, then the literature supports the low dose Eliquis as a relative. So typically that. So in worst case scenario, they will go home with for people who are getting recurrent thrombosis. I'll put them on Eliquis, Xarelto, as a Plavix combination, and sometimes. It's just sometimes obviously you can still do traditional Coumadin. The Coumadin issues, obviously, you have to worry about checking the INRs and all that, which is inconvenient for many patients. But usually within 2 or 3 would be for multiple thrombosis. Without thrombosis, I will just put them on aspirin and Plavix.
So the reason you put him on 4 type of
It
anticoagulant
was actually 3. It was actually 3. He was it was on Plavix, low dose Eliquis, and aspirin. All right.
So, but the justification for that is the severity of disease and the recurrency of nature.
Recurrent. Correct. Recurrent. In this particular case, recurrent. So individualized in this case because of recurrent issues with this young man. And he was, again, he has very poor runoff. And with recurrent thrombosis, he'll be a candidate for a major limb loss and amputation. So with him having this thrombosis within a short period of time, it was just better to add that extra dose of Eliquis to see if it could make a difference.
Got it. Thank you.
Thank you. Any other questions on this matter? If not, we'll come at the end of the case when we have a roundtable discussion and you can keep your questions still. If you have any more questions, we can do that. If you have any other questions you want to ask on this particular topic, we'll be more than glad to answer them for you. Yeah, okay, very well. Our next speaker, incidentally, is the last questionnaire. Dr. Sangodeyi is a renowned general surgeon and trauma surgeon who has been in practice for many years. He has a passion for international work. He's also the president of the World Health Mission. It's done some international work providing the care internationally. We're privileged to have Dr. Sangodeyi come today to talk to us on two interesting topics, and we would hear what he has to say. He's also the CEO and president of the Med-Surg Physician Group here in Beckley, West Virginia. Dr. Sangodeyi, welcome.
Yeah, thank you for the introduction. I'm glad we are doing this. Thank you, Dr. Oye, for putting this kind of beautiful conference together. We learn from each other, and I'm hoping I'll be traveling to Gambia next month for a medical mission, and I'm hoping all of you will be able to join us someday. It's a small country in West Africa. We're basically doing a gap analysis. About 12 of us are going from different part of the country to see their healthcare system, see how to help them on a volunteer basis. So I will be inviting all of you once we stabilize the program. So today I have two quick presentation just to stimulate everybody. It's not a long presentation for the student and the resident in the room. The first case is, let me just see here. Yeah, what is the diagnosis? Well, this is case number one. You look at this wrist on your left side. That is one of my patients trying to, just stop right there. So this is one of my patients. You will see the arm span in this patient is bigger, is longer than the head to toe measurement. So when you measure the distance between half fingers, right and left, and compare it with this, the arm span is almost 1.25 greater than the height. So can anybody make a diagnosis of what we're trying to get at? Let me show you more. Let's show the second, yeah. And this is another one. This is the patient in red or pink is my patient, and the other one is one of my manager. You see the thumb sticking out. If you do your wrist, your hand, and try to hide your thumb under your fingers like that, you see how her thumb is sticking out? So go to the next slide, Syed. Okay, good. So the same thing right here, the wrist. See that wrist? When she tried, this is a positive wrist sign. When she tried to put her, I think if you can try it yourself on yourself, stick your 3rd finger out and put your thumb and the 5th finger, try to touch your 5th finger nail with your thumb. In this patient, you could see how easy it is to do that. So that's what we call positive thumb sign, positive wrist sign, and obviously the answer is already showing you. This is Marfan syndrome. Do you have any questions or doubts so far? So this is very easy way to diagnose Marfan syndrome, the skeletal abnormality, the increased arm span to height ratio, the positive thumb sign, and the positive wrist sign. I was actually surprised that the incidence is this much, is 1 in 4,000, which to some people that would be called rare, but that's really not that rare actually. So this patient of mine, the whole family has Marfan syndrome. The son, the sister, the mom, the dad. So it's a real, and she's ready. I mean, when I took her picture, she wanted to hide her face, but she wants to come in to her to be a live presentation one of these days if anybody wants to have her come for presentation for medical student or resident to show classic sign of Marfan syndrome. She's got a very loud murmur, a little bit of pectus abnormality. But the most important thing is that cardiac-wise and related to vascular surgery, these people have aortic dissection and mitral valve prolapse and many other abnormalities. So that's case number one, just a short case to kind of stimulate everybody to read up on Marfan syndrome. I will entertain any question at this time or comment.
Dr. Shanga, that was an interesting case. Kind of interesting to see that in a live patient. I remember many years ago when I was in medical school in Texas, and you read about things in the textbook, and when you actually see a patient that has the problem, you're like, oh, you know, I remember I was in clinic and the attending pulled up an X-ray and said, "What's that?" And I looked online. I think that's dextrocardia. You know. So sadly, it's interesting to read in the books and then actually see a patient in real life, and we're able to put that together, and it stays fresh in our memories when we do that. So that's a very interesting case. Thank you for the presentation on that. Any other questions for Dr. Sangodeyi on this Marfan syndrome interesting case?
Yes, I had a question.
Yes, sir.
Did her family members with Marfan's, what happened in their lives? Did they suffer from early deaths or cardiac complications, or what happened to them as well?
Good. Well, surprisingly enough, I mean, because of the good healthcare system that we have here, many of these family members are very educated and they know all about what to watch for. Her son had a ruptured aneurysm and had to be rushed from Raleigh General Hospital to WVU, where they did the special graft because of the busted vessel, which is part of the complication. And he is well and alive. So to answer your question, their lifespan is pretty good because they follow regularly. This one follow with me on a regular basis because of pain in the shoulder, pain in the knee, cardiac murmur. As a cardiologist, they monitor her and they review, they check her cardiac status, echocardiogram, I think once a year or twice a year, I don't remember. So they've been pretty good. There are no early death that I'm aware of, but the whole family's got Marfan syndrome. It's a very interesting family, and they are all my good buddies, and they'd be glad to come to any live conference anytime.
Interesting.
This is Dr. Kashyap. Thank you, Dr. Sangodeyi, for presenting this very interesting case. And I actually remember my fellowship days when we used to do aortic arches, and we used to see Marfan's patients quite frequently. There was a tertiary center, and this is more so for the students, I believe. But apart from these, if you just look at those people, they will have so many features. Like, the reason why she's able to do that to her wrist is because she's got really long, slender fingers like spiders, and they are called arachnodactyly.
Right.
If you look at if you ask them to open their mouth, they have a high arched jaw, and their arm span, as you can see, is really, really great. But along with that, just their face is also very long. And they have a retrognathia. Their jaw usually goes back, flat cheekbones, eyes are very deep setted. So you take one look at them, and you can really have that clinical suspicion that is this Marfan's, and you just put your stethoscope on their chest. So great case. Thank you.
Yeah, this lady is very classic, and she's very proud to show herself up. But I told her I don't want to show her face. She didn't care, but I managed to put a mask on her face just so I can get her cooperation. So thank you. The next case is also very interesting. Syed, can you give me the next case? Yes. All right. Go to the next one, the next slide. Yes, good. Well, this is another one to kind of warn you about COVID. I mean, we had that 2 or 3 years of severe COVID pandemic around the world, globe, since this is a global conference. This is particularly interesting. As you could see, this is bowel. It's one of my patients recently, and you could see the dead bowel. The dark part, the dark portion is ischemic bowel, gangrenous bowel. I've had 2 cases like this within the last 6 months. And for one surgeon to have 2 cases within 6 months of this kind of thing shows that we should all be very cautious of this. Go to the next slide for now. Let me see the next slide. All right. So actually, this was the first time I mean, I operated on this patient twice. This was the original operation. The one you just saw is the second look operation. You can see about 105 centimeter of small bowel that was totally dead. So basically it's got the gangrene bowel. But can anybody guess what is the original diagnosis in this patient? So this is COVID, okay? We're seeing more and more of COVID with ischemic bowel. I mean, as you remember, one of the problems with COVID is coagulation, hypercoagulable state. So this patient came in with abdominal pain, and we didn't know what was going on. It was only very recent. Nobody wanted, we do COVID, we don't do routine COVID tests anymore. But from my experience about 6 months ago, I ordered COVID and he was positive. So he has the classic respiratory symptom that most of them had, but the belly was kind of not perfect. So actually CT scan did not really show this dead bowel at all. No pneumatosis like we normally see, but because patient was becoming septic and belly was distending, I decided to explore, and this is what I find: dead bowel. So resected it, re-anastomosed. I left because all the bowel kind of looked dusky. So it was either I open and close and just let him die, or there was no way I could resect all the small bowel and this patient will live. So I resected the most ischemic bowel, and that's what you are seeing in the picture. So go back to the previous picture you showed, Syed. Good. So this is the second look operation. Surprisingly enough, most of the bowel that I thought we died survived, and only a small segment of the bowel were left dead. So I resected, you could see the anastomotic line. So I resected the anastomotic area because it looks dusky, and the obviously dead bowel, and re-anastomosed. And I did well for a while, but became septic and died of sepsis and COVID and everything. We tried hard to, he was only 59 years old, but he also had problem with alcoholism and all kind of other diabetes, all kind of issues. So this case number 2 is just to warn you that don't forget that COVID can present like this. And it has been noted that about 4% of severe COVID we have ischemic bowel. It's probably more than that, because I think we overlooked this. When I went in there, most of the blood vessels to the mesentery were totally clotted. So what is the etiology in this? Nobody seems to know yet, but they're basically thinking, go to the next slide, Cyan. Good. So 4% of critically ill COVID patients will have mesenteric ischemia, according to the literature, but it's probably more than that as we all learn about this case. And we're all blaming microvascular coagulopathy in this case. I would like anybody to comment on this, especially Dr. Kashyap. So I'm not sure whether I talked to the younger surgeon in the hospital, Dr. O and Dr. Hayek, and they were aware of possible mesenteric ischemia with COVID, but nobody has really focused on this. But this is 2 cases within 6 months in one hospital. So I'm sure it's more common than 40% of critical ill COVID. So comments and questions, please.
This is thank you, Dr. for presenting this case. It is really, really important in today's day and age where we're still seeing COVID and COVID-related illnesses. Yeah, I'm definitely aware of the microvascular coagulopathy, and I'm sure Dr. Oye must have seen a few COVID patients who do have thrombosis. We have routinely seen patients with PE with COVID too, but this is a known phenomenon. I've read articles on this. I think the other aspect for COVID is actually chronic COVID in patients with bowel problems. So, as we know, they have chronic COVID of the lungs. There is something called as chronic COVID of the bowel, and they present with non-specific pain of the abdomen, like even after they have been treated with COVID several months later. And we don't understand exactly why, but it's a possibility that COVID is actually activating our immune system, and there's some kind of autoimmune component to this, but it can give rise to a picture, something similar to inflammatory bowel disease. And there have been studies where they took tissues like biopsies of the small bowel, large bowel, liver, kidneys, and obviously these were patients who were these were post-mortem biopsies. And I think one of the article was also in a patient who was alive and underwent colonoscopy and enteroscopy. But they have shown that fragments of COVID, not the entire virus, but fragments of COVID live in the tissue for several months after they have completely recuperated from COVID, leading to this chronic COVID illness of various organs, not just the lung. So yeah, definitely this is something to be aware of as general surgeons, and great presentation. Thank you, Dr. Sangodeyi.
Yeah, I mean, I would think maybe there are probably some low-grade ischemia in these bowel cases that we're seeing with chronic non-explainable abdominal pain, diarrhea, bloatedness in this post-COVID syndrome. So that's something we should all be aware of, but you don't want to, the earlier you think of possible mesenteric ischemia or ischemic bowel in this COVID patient, the better chance of saving their life. The 2 cases I saw, both of them succumbed because we couldn't save them. It was just too much sepsis and just bad. Thank you very much.
Yeah, Dr. Sangodeyi, a question for you. Did CT scan show anything about the SMA in terms of occlusion thrombosis of the SMA, chronic or acute?
No, not the SMA, but there was some suggestion of venous thrombosis. The radiologist that read it, and even when I review it, for some reason we didn't really see the typical features of ischemic bowel. They kept just saying ileus, but there was no SMA occlusion at all. No.
I have a question too. This is Dr. Lanny Wilson. Dr. Sangodeyi, your questions about anticoagulants with the first case makes me think that you know a little bit more than the average person about anticoagulants. How about the use of anticoagulants for these COVID cases to help prevent this kind of problem?
I mean, I don't know what the medical team does with the regular COVID. I'm not sure whether they automatically put them on Venous or somebody has to help me with that, or heparin when they acutely present with COVID. But it would be something to look at. Maybe obviously this may prevent, treating them with anticoagulant may prevent this kind of problem, because we know part of their problem is increased coagulability, you know, and they end up with PE, DVT, similar thing. Yeah. So.
Thank you, sir. I know that anticoagulants are recommended in some cases, but I don't know enough about it to recommend. So you seemed interested in anticoagulants earlier, so I thought maybe you might have a clue here. Thank you.
But that's something I will review with the ID doctor that are treating a lot of these cases.
Sure.
As to what's the role of anticoagulant in this patient?
Okay. Thank you.
Typically, they have increased coagulability.
Great presentations. Thank you, sir.
Thank you. That's all. That's all I have. Thank you.
Dr. Sangodeyi, with respect to COVID and thrombosis, arterial thrombosis, we see in peripheral vascular disease segment, and during the pandemic, we certainly did have our share of patients with COVID-related issues. One of the things that we're able to do for the lower extremities and upper extremity was the use of TPA therapy intraoperatively to treat these patients. I'm not sure if, and that's the reason why I was asking if the SMA was evaluated on your two patients to see if they had any issues with that, and see if there would be a role for even mechanical thrombectomy if there was blood clot in the artery. So I'm not sure if Dr. Rowe has any comments on this from California.
Yeah, thank you for those cases. And with the COVID case, I was wondering, I wonder if this was more of a case of mesenteric venous thrombosis presenting with gangrene, which is kind of a rare outcome for mesenteric venous, but it can happen. What were your thoughts when you operated on him, Dr. Sangodeyi?
It was mainly venous. It was the artery was perfect. It was mainly venous thrombosis. You know, that was basically what I saw. And then, but to answer Dr. Oye's question, I'm going to re-review the CT scan to look at to see whether they can look at the SMA. But mainly, this was venous thrombosis.
Very well. Yeah, thank you. Dr. Ugoji from Warri, Nigeria has a question for you, Dr. Sangodeyi. Remember Dr. Ugoji?
Yeah, how you doing, doctor? I think you are muted, doctor. I think Dr. Ugoji is muted.
No, Dr. Ugoji.
Yeah, thank you. Good. Good. It's afternoon here now.
Yeah, that's fine. How you doing, doctor?
I'm fine. I'm really fine.
Good.
It's nice to be seeing all of you and to be part of this. Thank you, Dr. Sangodeyi. I remember you very well.
Yes, I remember you too.
It's a pleasure seeing you again. Thank you for those cases, especially the first. I wanted to just commend you at the first case, the Marfan syndrome, for stimulating residual memory with that case. Very stimulating. Yeah. Thank you. But this
should be a good basketball player with those arms.
Not at all. The case you just presented, the COVID case, I was just wondering, you know, you mentioned that the patient was diabetic. Yeah, I was just wondering, you know, diabetes being a monster, you know, is it possible it could have been could have contributed anything to the gangrenous bowel, the mesenteric ischemia?
Well, to the extent that, you know, COVID get worse in patients with comorbid condition like diabetes, obesity, and all those stuff. So to the extent that this patient is diabetic, his COVID probably got worse based on that. But I don't think, we don't just see bowel ischemia just because they have diabetes. Actually, his hemoglobin A1C was pretty decent. So it wasn't, it was a well-controlled.
So it was controlled.
Yeah. Yeah.
That's control, so not likely.
But
Thank
people
you.
with
Thank you for the
diabetes have
presentation.
increased chance.
Thank you. Thank you.
Very well, Dr. Shanga. Thank you so much for the interesting presentations. We look forward to seeing you on our next global ground rounds in April. Thank you so much. Yeah.
And what I'm going to do when I go to Gambia, we're visiting their new teaching hospital there in Gambia. And I will try to talk to you, Dr. Oye, to see whether we can hook them up to participate in this global conference. They need a lot of education. I'm actually going to give a lecture on breast cancer to the student. They just started their residency program, but it's going to be interesting when I come back to see how we can hook them up to your program.
Very well. Along those lines also, we're seeing a lot of colorectal cancers in Africa and people of African descent. So more so than usual. So we'll continue to work with that. And that's the purpose of this program, to educate, interact, and share our experiences. Thank you so much, Dr. Sangodeyi.
Thank you.
All right, our next presenter is Dr. Sunanda Tah. He's a general surgeon, trauma surgeon here in Bakr, West Virginia. He trained in Houston and at the Houston Cardiovascular Center, and we're pleased to have him present an interesting case. He'll tell us about his case.
Thank you, Dr. Oye,
Okay.
for the introduction.
Dr. Sunanda will be presenting for you. Is that what I hear?
Yeah.
Okay.
Sunanda.
Okay, Dr. Sunanda Tah, who's a medical student, will be presenting this case and will have comments from her. Okay, thank you. Go ahead, Dr. Sunanda.
It says I can't share my screen to share the PowerPoint.
Yeah, we can see it.
Yeah.
Saad?
Yeah, I'm busy now. So whatever is not an emergency, let it wait. Yeah?
Can you just press on share and then
It says host disabled.
do you have your
participant.
presentation open?
Yes.
So go on Zoom, press share screen, and
It says host disabled participant screen sharing.
just let me see.
Sunanda, you are still in Chicago?
Yes, so in Chicago. I'm coming back next week.
Okay, very well.
Thank you.
Make her a host?
Yeah, you have to make her a co-host. The only hosts are allowed to share their screen.
Okay. All right, so I made you a host. You can try sharing that.
Okay.
Does it allow you now?
Yeah, it works now.
Okay.
Thank you.
Okay.
So hi everyone, my name is Sunanda, and today I'll be presenting an unusual presentation of C.Diff in the small bowel, which I got to see when I was doing my surgical rotation with Dr. Kashyap. So today we'll be talking a little bit about C.Diff, the risk factors, fulminant C.Diff, and then we'll talk about the case, and then followed by a small discussion about C.Diff, small bowel, and Pittsburgh protocol. So to begin with, C.Diff infection is a leading cause of hospital-acquired diarrhea in the United States. According to the CDC, it's estimated to cause almost 500,000 infections in the United States each year. CDI occurs in individuals that have recently received antibiotics that lead to alteration of the flora of the colon. The two main toxins produced by C.Diff are toxins A and B, and these toxins damage the lining of the colon, causing inflammation and diarrhea. So some of the risk factors of C.Diff are being 65 years or older, a recent stay at the hospital or nursing home, weakened immune system, such as people with HIV/AIDS, cancer, or organ transplant patients, patients with a history of inflammatory bowel disease, previous infection with C.Diff, or known exposure to pathogens. However, community-acquired CDI is also known to occur in healthy individuals. So fulminant C.Diff is a severe infection characterized by the presence of hypotension, shock, or toxic megacolon. It is uncommon with an incidence of 3 to 8%.
It is characterized by a mortality rate from 34 to 80% with surgical management versus 50 to 70% mortality rate in non-surgical care. Standard treatment includes aggressive antibiotic therapy with vancomycin and metronidazole, along with colectomy and ileostomy. So now we'll talk a little bit about our case. So we had a 60-year-old female who presented to the emergency department with non-bleed diarrhea, vomiting, poor appetite, abdominal cramps, and generalized weakness for 4 days. Past history was significant for IV drug abuse, neuropathy, deep vein thrombosis, anxiety, and depression. So at presentation, the patient was stable. There were no signs of peritonitis. However, over the next 2 to 3 days, her clinical condition worsened. She developed hypertension and tachycardia, her leukocytosis and lactic acidosis worsened. The stool assay was positive for C.Diff, oral vancomycin and IV metronidazole were given. The CT scan revealed small bowel ileus, but none of the colon was ascended, as we can see in this image. And medical management was maxed out without any improvement in her clinical condition. Since she wasn't improving, we had to do a diagnostic laparoscopy, which revealed necrotic small bowel but a healthy appearing colon. An exploratory laparotomy and resection of the small bowel were performed. The length of the small bowel that was resected was 70 centimeters. The length of the terminal ileum towards the ileocecal valve that was left behind was approximately 8 inches. Post-operative day 3, patient underwent a modified loop ileostomy. Catheters were placed proximally and distally in the bowel loop. So as you can see in this image, we took this image when we did the diagnostic laparoscopy, and the second image shows necrotic small bowel. So in terms of her recovery, the patient had ileus for a prolonged period, which made the administration of oral vancomycin difficult. IV metronidazole treatment was started. Vancomycin was administered through the long rubber catheter. Polyethylene glycol and vancomycin were flushed through the distal loop of the ileostomy daily until the WBC count normalized. The pathology report confirmed pseudomembranes in the resected small bowel. C.Diff was confirmed from ileostomy samples. The patient recovered well and was eventually transferred to a nursing home. So it is important to note that C.Diff can infect more than just the colon. Small bowel CDI presents a unique challenge in many ways. Patients can have ileus, making it difficult to start oral vancomycin, which is the standard of care. Patients with this unusual presentation typically have some type of predisposition, with colectomy being the greatest risk factor since it alters the small bowel flora by disturbing normal peristalsis and the function of the ileocecal valve. In our case, however, the patient had no prior colonic surgeries, making this case even more unique. We hypothesized that C.Diff retromigrated from the colon to the small bowel across the ileocecal valve. In our case, we also used the Pittsburgh protocol in addition to the standard treatment. Pittsburgh protocol consists of colonic lavage with warm polyethylene glycol through the loop ileostomy followed by vancomycin flushes. This protocol was first used starting in June 2009 to January 2011 on 42 patients that were diagnosed with fulminant C.Diff and were treated at the University of Pittsburgh Medical Center. Using this strategy, the researchers found that the preservation of colon was achieved in 93% of their patients. Subsequent articles have reported that the mortality rate in the set of patients that this procedure is used on is around 19%. So in conclusion, as CDI continues to increase, not just in the US, but worldwide, the incidence of small bowel CDI may potentially increase as well. Patients with small bowel CDI present with symptoms similar to C. diff colitis. On imaging, the colon may appear normal or unaffected. As demonstrated in our case, early diagnostic laparoscopy or laparotomy should be encouraged in patients that do not respond to medical management or clinically worsen despite treatment. Thank you for listening to the presentation.
Thank you, Dr. Sunanda. Nice job.
Thank you. Thank you.
Thank you. Dr. Kashyap, you have any comments on your case?
Yeah, I think this was slightly unique for the reason also because when we did the CT scan for this patient, there was no evidence that the small bowel was involved. And she had dead small bowel, but there was no evidence of that CT scan at all. And surprisingly enough, the colon was normal too. So, you know, we see a lot of C. diff patients who have ileus, but this patient just would not improve, and that prompted us to take her to the operating room. And although this is a known phenomenon, there are probably less than 200 cases of small bowel C.Diff reported in worldwide literature. So that, I think that it's unique, and we got to be aware of this. So probably if the patient's not getting better and the colon looks normal, because this is not a typical case of fulminant C.Diff or toxic megacolon, but this is where the small bowel is behaving that way as an toxic megacolon would behave. But that can be diagnosed only if we do a diagnostic laparoscopy or a laparotomy.
Well, this is Dr. Sangodeyi. Thank you for the presentation, Dr. Tah, T-A-H. Can I call you Dr. Tah? Good.
Thank you.
Are you both going to write this up in the literature? Because this is very, very unusual. You're going to be able to write this as a case presentation or something like that, review the literature, yes or no?
Yes, we are. Thank you.
Good. So the only comment I have for the young doctor is that scientifically you should try to use centimeters instead of using inches at all, because initially you talk about 75 centimeters or something like that, and then you said 8 inches.
Okay.
That should be converted to centimeter and not talk about inches at all. I know. I know in this country we're still using the old system, but as scientists and doctors, we should really be using centimeter, kilogram, and all this stuff. But this is very good presentation. I thank you very much for the knowledge.
Thank you.
Thank you so much. Again, the C.Diff issue is a problem as well known in hospitals, and the over-generous use of antibiotics obviously could be implicated. It's important that we don't put patients on antibiotics that don't need antibiotics. So very, very, very nice case presentation, Dr. Tah. And we'll hope to see you next Global Ground Rounds in April. Thank you so much. Yeah.
Thank you.
Our next presenter will be coming to us from Warri, Nigeria. He is Dr. Uche Ugoji. He's the medical director of the Salem Hospital. Dr. Ugoji has had a very unique experience with Dr. Sangodeyi and I when we traveled to Nigeria to work, and he's always been a good participant of our global conferences, the yearly endovascular conference for Africa. With Dr. Ugoji participates in those conferences, and he's quite dynamic. We're excited that he's able to join us today from Nigeria and with his presentation. Dr. Ugoji.
Thank you, Dr. Oye.
Thank you.
I'm honored to be part of this global one run. I'm pleased to meet all of you.
Good.
Can I be heard?
Yes, we can hear you.
Okay. I guess I can share my screen now. I'm disabled. My screen is disabled.
Okay, we'll work on it for you.
Okay, all right, thank you.
Just give it 1 second, we'll put you on. So how's Warri today?
Warri is fine.
The
much awaited Nigerian presidential election is ongoing. Okay. Voting has started.
Okay, no violence yet?
No violence, quiet everywhere.
Very good.
I didn't have the opportunity to vote.
Very well.
Well, while you're working on this, I think Dr. Wilson had a question.
Sure. Dr. Wilson?
Thank you for that opportunity. My question was simply, was this patient co-managed with infectious disease? I'm quite sure she was. And then was the flora addressed at all, returned to normal flora in some way in this patient to help her cure, in addition to your surgery, of course?
Yes, to answer the first part of the question, infectious disease was involved in the treatment of this patient. The reason why infectious disease was involved is because she needed IV metronidazole for a long course of period, and not many of us are aware, because metronidazole is like a drug we use very frequently without any side effects. But when it's given over a longer period of time, then it can lead to neuropathy, and that needs to be monitored. So yes, ID was involved into that care. And initially we were not able to give PO vancomycin to this patient. So we had to give that through the catheters to this patient to treat the enteritis part of it. And although the colon was normal, we did also adopt the Pittsburgh protocol. And that's because we believed that the C.Diff retromigrated from the colon into the small bowel. So we treated the large bowel or the colon as C.Diff as well. And we did get samples of stool on flushing through the ileostomy, and that was positive for C.Diff too. So that was the other reason. And the second part of the question you said was, did we test for normal flora?
Not test for it, but did you address trying to return her normal flora? Some people even use pellets of stool that have normal flora in it. I was just wondering if in any way you tried to address returning normal flora back to her system.
And I think that's an excellent question. We did not try that. She was recently readmitted with some ileostomy complications, but not with C.Diff. We tested her and she was negative. But I think that's a great thought. I just don't know if we would need some kind of privileges, or because it will be like something's different from what is a standard of care. So also we'd have to obtain stool, test it, make sure that it is good enough to be implanted into another patient. So I don't know what the nuances or legalities of that is, but I think it sounds similar to a fecal transplant, which some of the centers do. I had a few difficult patients with prolonged and recurrent C.Diff that I had to send them for fecal transplants, and they did great with that. But yeah, I think that's a good thought, and I should probably think more about that and try to get things working around it.
Great.
Just
Great case.
FYI, Dr. Siddiqui is trained in fecal transplant. Whether he does it recently, I don't know, but I know he is trained in fecal transplant.
Yeah, and unfortunately, our hospitals actually are a problem. I know Dr. Siddiqui is very interested, but our hospitals are a problem. They are not allowing that procedure to happen currently.
Good, I understand.
Thank you. Great case.
Thank you so much. In interest of time, if we can get Dr. Ugoji on directly, we can get to Dr. Rowe and we'll come back to Ugoji. Okay, we have some technical difficulties with Dr. Ugoji. So let's go to Dr. Rowe. Dr. Rowe, are you there?
Yes, I'm here.
Well, why don't you go ahead and present your case, and then we'll come back to Dr. Ugoji.
Okay.
Dr. Vincent Rowe is the professor of surgery at UCLA and the chair of Division of Vascular Surgery and Endovascular Surgery. He's also part of the Black Society of Vascular Surgeons and a member of the Society of Vascular Surgery. He is a dynamic person who has interest in advancing healthcare globally. So we're excited that he's going to be part of our program today to talk to us about the topic of interest. Dr. Rowe, thank you.
Yes, thanks. Thanks for inviting me. It's been some wonderful cases presented. So thank you to all the participants and the listening audience. And thank you, Dr. Oye, for all your work that you're doing and putting this together, and your work in Africa and in West Virginia. Really appreciate your dedication to the field and educating our physicians.
Thank you.
This is just a short case. It's more of a case to see what people would do and kind of share where I think, the wrong thing. So sometimes you learn from your mistakes quite well. Carotid disease is pretty prevalent in our country, and it's something that most cardiovascular specialists will be familiar with, either with an open approach like this endarterectomy or the carotid stenting. And this case somewhat combines both. If you're able to do carotid endarterectomies, if that's in your practice model, this is what you'll end up seeing, a beautiful plaque with the ulcerated process into the internal carotid artery, most of the area that leads to the embolic phenomenon that we see with the patients that become symptomatic, and then the plaque heading out into the external carotid artery as well. Now, we've been doing this for quite some time. The first one was performed by Dr. Carrera, a neurosurgeon in Buenos Aires, and he had a 41-year-old patient with aphasia and hemiparesis. And this was how the first carotid was reported to be done. As opposed to cleaning out the plaque, he simply moved the internal carotid artery here, left that plaque as a stump, and then moved it over to the external carotid artery, and then ligated the external carotid artery. We don't do it that way, obviously, now, but it was a rather ingenious way of handling the disease at that point. He most likely eliminated the risk of any embolic disease occurring while he was repairing the plaque, but often probably did not have a way to shunt. And actually, if you now go back to what we're doing more modernly, you see it's almost related to how people handle with the eversion. Just by cutting the artery and then reanastomosing. He just moved it over to the external carotid artery. And follow-up was good in the literature with 39 months. Now, Dr. Tabeki was felt to do the first one here in the United States, 53-year-old patient, 2-year history of transient ischemic attacks. That patient was very fortunate to not have had a severe stroke after 2 years. And that was a successful endarterectomy with 19-year follow-up. And he did more of a traditional approach without a patch, just removing the plaque and closing the vessel back. Problem was it wasn't reported in the literature until 1975. So that's the debate as to who did the first one and when was it done. But the reports have it as 1953 for Dr. Tabeki and 1951 for Dr. Carrera. And since then, if you look at all the literature from way back from these early reports, you can see that we're reporting over 400 to 500 cases annually talking about carotid disease. So it is a big part of what we deal with in our cardiovascular specialties. Just to talk about some of the high risk factors, this was a paper that was done, and I think it's confirmed by most of us that the physicians have pretty much figured out who are the patients that are at higher risk. And these were some of the risk factors: contralateral occlusion, needing an emergent procedure is always a high risk. You're always concerned about what's going on in terms of the perfusion of the brain, and was there a thrombus that led to that symptomatology. And then, of course, having some type of ipsilateral cyst disease and symptoms. And if you can add these as well, patients that have a higher risk based on their anesthetic issues. Again, emergent intervention, high bifurcation, as well as severe pulmonary disease and prior stroke. So here's the case. I had a 68-year-old female. She had a history of hypertension and hypercholesterolemia. She presented with all of this dizziness, with exertion, lightheadedness, not very typical of carotid distribution symptoms, did not describe any lateralizing signs, and basically just would lose her balance and have these symptoms once she started to exert herself. She had a carotid endarterectomy done at an outside facility for asymptomatic lesion 1 year ago, but that doctor told her that carotid was now occluded and there was nothing that could be done for her. She came to see me, and this was the duplex scan that I have. And you could see there was significant on this. This is the left side that had been operated on. You can see the flow into the internal carotid artery was rather strange, very high resistant, with end diastolic velocities going down to 0. And there was a significant common carotid lesion. So I tended to believe that this needed some more imaging and just wasn't sure what was going on. On the right side, you could see there was significant subclavian disease, as well as external carotid disease. and internal carotid and distal common carotid disease, pretty much close to the criteria to meet 80 to 99%. A very high grade external lesion, and again, subclavian lesion. Her vertebrals were not terribly affected. So to me, this was somebody that just had significant disease bilaterally. If the left side turned out to be occluded and was occluded, the right side still had some very bad disease and even was affecting the external, which would be her collateral pathway. So I ended up getting a CTE angiogram. And here's the CT angiogram of the left side. And you can see here in the lateral view comes up very high grade stenosis. These are the surgical clips from the outside surgeon. And then it looked to me like it just stopped about right here. If we look at the frontal view, you can see again the common carotid, the very high grade stenosis. And then it looked like it bird beaked to about here. I could not tell. This was the external, I felt, transitioning around. And then here was the internal that appeared to be stopped and occluded. Very tortuous vertebral. And let's take a look at the contralateral side here on the right side now, where she's having these global symptoms. You can see some calcified plaque. And if we just look laterally, you can see that right here is the ICA heading up and some pretty calcified plaque. Remember, the duplex showed it to be somewhere in the 80 to 99% range, just I'd say about 80% stenosis. This was the duplex we had. Again, the left side is the side that's felt to be occluded. And you can see the common carotid proximally, lots of intimal hyperplasia from her prior surgery, and some velocity shifts as it traversed up to the internal carotid artery. Here's the area of that high-grade stenosis that we talked about and that bulbous patch that was performed. This was that 600 velocity we talked about. In the left side, that again, this is the side that had been done. And then here was the ICA, and we talked about that occlusion at that with the bird beaking effect, pretty much seen on duplex and CTA, but they did see some flow distally. It was hard to say whether this was the external or the internal. So they did a temporal tap and thought that this could be the external carotid artery. And that was traversing through that really high grade, that big bulbous patch and heading up to the facial muscles. And then they said, well, we think this could be the internal carotid artery filling retrograde. And I said, but that usually is the opposite. Usually it's the external, that would, go from high to low, that would feed an occluded internal. And so they said, well, we're just not sure, but we think this could be a retrograde ICA. And Hare had more evidence of it. Again, resistance 0 though, so I felt it was a high resistant pathway. So, some questions for the audience. We'll start with the second question. Does she have a carotid occlusion or the term pseudo-occlusion? Any comments?
Yeah.
All right.
This is Dr. Kashyap here. I think she does have carotid artery occlusion on that side. It's very unusual, like within 1 year to have this severe occlusion after a patch repair. So
I agree with you.
Yeah.
Would anybody need further imaging? She says again, her symptomatology, she exerts herself and she just gets globally lightheaded, dizzy, not lateralizing signs.
Would you
And then, go ahead, Dr. Oye.
Would you consider catheter arteriogram if you're concerned that you really have occlusion or don't have occlusion? Could you put that to rest by doing a catheter arteriogram selective?
I think that was a critical decision there. And I think it would have turned out to be the right decision. I didn't do that though. I felt that with the right side so significant, the right subclavian, I thought that was affecting her vertebral, and then the 80% stenosis, and I felt the left side was occluded. I moved forward with I recommended an endarterectomy of that right side.
Okay.
And again, this was that right-sided lesion. And she had the subclavian stenosis. So I felt she was more someone dealing with global hypoperfusion to her brain with the exertion and the left-sided occlusion, right-sided subclavian disease, and then ICA disease and external disease. So that was my diagnosis. And we went ahead and did that right side, and she continued to have symptoms, continued wax and waning symptoms, and basically just didn't get better. So after about 6 months, I kept checking my carotid side. It was okay, it was okay, it was okay. I said, okay, let's go for the catheter-directed angiogram. And so Dr. Oye was right. Here's that left side. It was not occluded.
Interesting.
And you can see that high-grade stenosis on the patch. This was the external, and the duplex was right. My ultrasonographers were better than I thought and had better clinical judgment. And so this left side was the cause, because me fixing the right side did not improve her symptomatology. I thought it would have helped significantly, but it did not. And then this side, how would people treat this side?
Two options. Option number one, you could probably stent it. Option number two, you could do an extended endarterectomy with a patch.
Would you consider TCAR or anything? It seems like it's too low down for that.
You could probably manage. TCAR would be a good option. When I say endarterectomy, when I say standing, I'm looking at the TCAR. Obviously, it has better results than transfemoral stenting. So it's either TCAR or is one option, or if you can get it, of course. And the other option would be extended endarterectomy with a patch. And the third option could be even direct stenting of the carotid. You stick the carotid and clamp the proximal area and just stent it. So
yeah, I mean, this is almost in the classic area for a clamp injury here, or either they just had a significant stenosis at the time of endarterectomy.
Sure.
So the decision was for a stent, significantly oversized here, but did get excellent flow up into that system and resolved her symptoms quite well. Oh, this is the right side. Oh, I forgot to put in the left completion side. Oh, sorry. Yeah, but she ended up getting stented and did quite well and resolved all of her symptoms, and she did okay. But I think the key point was I didn't move forward with additional imaging. I think if I had to do it again, Dr. Oye is right, I should have done that. And two, sometimes you see cases that other people had operated on. I think it's almost imperative that you work that case up even more, because you just don't know exactly what you're dealing with. And I think at that point, I think the suspicion should have been high when she presented to me, to make sure that that side actually was occluded. And so the additional imaging, I think, would have led me down a different pathway with her. So thank you.
Thank you. Excellent case. That's interesting. Very, very interesting. We see a lot of carotid disease in West Virginia, and that is really, really nice. So you all have that too in California, I take it.
Yeah, we don't have it as frequent, but they don't smoke as much, but there's still carotid disease, that's for sure.
Yeah, very, very, very interesting case. Like again, TCAR, it's a great thought. Would you have considered TCAR on your right side? On the right side you did?
I probably should have. Yeah, I haven't been a rapid adopter to TCAR. I've kind of lagged behind. so I do it more selectively. But I think it's the way of the future. And, you know, I've been giving them to my younger partners to get them going. But I think now I may just have to take some for myself and just move ahead with it. But I think it's the future.
Yeah, again, with any technology, we have to take any technology with a grain of salt. TCAR is a great tool in our endovascular toolbox. Again, there's no comparison when you have some person that has extensive calcification of the artery. Putting a stent in a markedly calcified artery is just begging for trouble. You well know that. So sometimes the best option is really the classic carotid endarterectomy, especially if I have a high-riding lesion. You can do eversion technique, and that works quite well, as you've shown on your presentation. Yeah, so I'm with you. I do the TCAR, but I'm quite selective because I think open carotid endarterectomy is still a great operation.
Yeah, I love it. I mean, and it gives us a balance. You have some faculty pushing TCAR and some that still do endarterectomy. The trainee gets to see both and make sure that they can do everything when they finish. Dr. Wilson?
Yes, thank you. I'm an OBGYN, so I'm sorry, I don't know what a TCAR is. Can you explain that a little bit?
Oh, sure. So the stents in the carotid have proven to be very effective, and we can come all the way from the groin, navigate around the arch, and then head up the internal carotid artery and place the stents. Obviously, you have a long distance, and there could be some tortuosity or changes in the arch, depending on the age of the patient, that could lead to micro or macro emboli when you're doing the procedure. So some very smart people came up with the fact, why don't we cut down right here on the carotid artery and stent the patient from here? And so it's basically cutting down on the carotid artery here, open through a small incision, placing your sheath, and then performing the stent from here. And the really remarkable science for the TCAR is the fact that, so to eliminate or significantly decrease the risk of any emboli heading up to the brain, they have a reversal of flow technique. And so then you turn on the reversal of flow and have that flow reversed in the ICA and drain down into your femoral vein through a long catheter that you put into the femoral vein. So it's really remarkable that that works and the patients tolerate it. And Dr. Oye, you have any comments about it?
Absolutely, that's it's a great operation when patients well selected. The only time I've had an issue with it was a case where there was a significant calcification, and in our patient population, we tend to have heavy smokers, bad calcification, and when you do that, the stent, in my mind, may not be rigid enough to keep that area patent, so you can get restriction of flow a few days or after the event, or even a near occlusion. So if in those cases, what with significant calcification, I just do carotid endarterectomy. If it's a soft plaque, if it's a high riding plaque, the TCAR is a great surgery tool for that, because you can put a stent much higher, and it's easy for the patient with the reversal flow. They have less issues with stroke. So that's that. It's a great operation, but patient selection is always critical, as you well know.
Thank you so much.
Thank you.
Hi, I had a quick question. I'm Yeti, one of the medical students.
Sure.
Thank you for your presentation. It was great. I was just wondering if there were any absolute contraindications where you would not be using the TCAR and would go to open instead.
One of them is the distance between the clavicle and the carotid bifurcation. You have to have enough room to be able to work. So if the bifurcation is actually very low and you don't have enough room to place your sheaths, that's one of the main complications. Tortuosity in the carotid seems to be well tolerated with TCAR. And I think Dr. Oye mentioned severe calcification can be combated with some really high-end maneuvers and trying to break up the plaque, but I think for most people, they would not move forward with a stent if the artery was if the plaque was very calcified.
Okay, thank you.
What is your conversion rate if you think you can do TCAR and you start it and you end up doing open endarterectomy? Do we know the conversion rate?
I would say from what I've seen in the literature, it's very, very low. I'd say probably in the 1% or less range. What have you seen, Dr. Oye?
Yes, it's low. And one case I did have was a case of a marked calcification where we thought we could do a TCAR, and we did. Then postoperative patients developed significant restenosis, and I don't think the stent that's currently being made for TCAR by one company is rigid enough in those cases. So I was able to, I had the option to go back and re-stent. I just figured it was just better to take the plaque out. So I just went in and took the stent and plaque out and patched. So yes, it is very low, but again, when I keep saying patient selection is critical, it's for that reason. Yeah, I don't want to put a stent with the intent that I'm going to go back and remove the stent because of calcification. Yeah.
Yeah, I think the low conversion is a marker for good patient selection. The criteria, people stick to it fairly closely.
Well, I mean, with any new technology, I mean, I remember when we first started doing laparoscopy, and the conversion rate was very high, but as we learn and the conversion rate to open reduces. So with any new technology, there will be this initial thing, but I agree with those two vascular surgeons. Your selection criteria is very critical. So I really appreciate Dr. Rowe persistent. For the students in the audience, the general lesson from this presentation is the fact that don't ignore what the patient is saying to you. Don't assume that what they're saying is not right. So this patient continued to have symptoms, and Dr. Rowe was very persistent and reevaluating and doing the other side. And we have a very good outcome. These are very, very critical lessons. Thank you very much.
Dr. Rowe, this is Dr. Kashyap here. Quick thing. You had 3 questions on your slide, and the first question was which side would you operate first and which would you operate second? I think if I was to take my boards and if this case was presented to me, I think I would still say I would operate on the right side first. Do you agree?
I think that you could argue the right side. I mean, I talked myself into the right side because of the sequential stenoses and the lack of the external. First of all, I don't think they would give you this on your boards. It's too.
They must be.
But I think, the comment about continuing to work up, I think that's key. And yeah, I don't think you could be faulted, but I thought the key decision point was not to do the angiogram first. I think the angiogram, I believe the CT, I thought it was a very good CT. And but if you look at it closely, there was a discrepancy in the CT and the duplex. And that should have led to the additional imaging. And I didn't believe the duplex. I said, I can't see that as being possible. So I think that was my critical decision. And that was where I should have got the additional imaging early. And maybe she would have ended up with an operation on the right as well. I think she probably would have because she had significant disease, but we would have at least cleared up that left side.
On that topic, Dr. Kashyap, again, when we do carotid endarterectomy, we tend to do the worst side first because we want flow through the good side. So on the boards, I would, by doing this like arteriogram, if I know that side was salvageable, the left side, then I'll do that first, hoping that the flow from the right side will hopefully keep me going so the patient doesn't have a stroke during the procedure. But yeah, it's an interesting case. One of the questions we had on the chat room was the use of statins. Yes, we'll do use statins for patients, especially carotid, the vascular patients in general. And for patients with carotid endarterectomy, especially with TCAR, the difference is we also give them Plavix, aspirin, and statins prior to procedure. If you don't anticoagulant adequately, you sometimes can get postoperative thrombosis. We check the blood, in terms of the thinning done at time of surgery to make sure it's adequately anticoagulated. If they're not, we give them additional heparin during the procedure. So those are the things that we do with patients that have TCAR. TCAR is a new tool on the block, but there's some things again for the medical students and residents. You have to make sure a patient going for TCAR surgery, you don't keep them, you don't stop anticoagulation. You have to continue anticoagulation prior to surgery, not stop it like we typically do for other surgeries. Yeah. All right. See if we can get Dr. Ugoji back. Thank you, Dr. Rowe. Excellent presentation. See if we can get Dr. Ugoji back. Thank you, sir. Dr. Ugoji back if it's through. Dr. Ugoji.
Yeah, I'm
Okay.
ready to share my screen. Can I?
Yeah, go right ahead, sir.
Okay.
Yeah.
Excuse me. I can't.
Well, we were able to see what you were projecting. So after you projected, you can just start your presentation and it should be okay.
Yeah. Let's see. Oh, thanks. Wow. What's happening? Excuse me. Okay. I can't get to share.
You can just press share screen and it should show you a tab which shows your presentation. And so and you click on that and that, start projecting.
I've done that, but what I'm seeing is share screen.
Yeah, on the Zoom call, share screen.
Yeah, I've done that.
When you click that, it should show you a number of tabs, all the tabs open on your computer. And
no, it's not showing me that. That is a problem. Showing me Dropbox, Microsoft.
Is your presentation open on your computer?
Yeah, it's open.
Okay,
it's open. I don't know. Oh. It's open. I have it. I don't know.
You did that earlier. I could see your screen before when you initially did it.
What happened? What? I'm sorry. I can see it, but you can't see it.
Do you want to like summarize the experience and even though we don't have
Okay, maybe.
just
Well,
summarize
that's
experience and we'll summarize experience and hopefully if you can get the pictures later on, you can certainly show pictures to us. Just summarize the
okay.
experience and then we can see you.
Oh,
We can obviously see you, so you can certainly summarize the experience and we'll, if you can pull up pictures later, we can take a
You
look
did
at it.
project it. We saw the Zoom thing on your computer. So
yes, I did.
yeah. So
And share screen, I'm sharing screen, but the slide is there. I see in the box, I see something like
when you press share
Dropbox.
screen, it should show you tabs, all the tabs open on your computer, and you can select which one you want to project.
Unfortunately, what I'm seeing are not the files I have on my computer.
Okay,
I don't know
that's
where
fine.
that is.
That's fine.
Yeah, so
Let's go
I
ahead.
think
Go
I
ahead.
should just,
Yeah, just give a summary and we'll
Yeah.
go ahead and if you can find them later on before, we can always bring pictures.
okay, this, the case I have, it says 62 years old housewife, a non-hypertensive, presented with over 30 years of varicose veins and 15 years of history of right chronic leg ulcer and 2 years history of burning sensation in the affected legs that disturbs her sleep most nights. She denied any history of antecedent trauma to leg before the onset of ulcer, but admitted to prolonged standing over the years doing her home business. The onset of varicose veins were during pregnancies. She is a multigravida, and one of her daughters currently has varicose veins. Few years before presentation, she was placed on compression therapy with limited benefits because the wound would heal and break down often, usually within few weeks to months. The sizes of the wounds at different times for the past years range from 6 cm by 4 cm to 12 cm by 8 cm. The physical examination at presentation in our hospital, she had a blood pressure of 165/80 and pulse rate was within normal limits. Ankle breaker index was 1.4. The BMI was 21.96. She had strong dorsalis and posterior tibial arteries and pulsation. And she had extensive bilateral varicose veins, more prominent on the right, with the right malleolar poorly granulating chronic ulcer measuring about 6 cm by 8 cm. I have the pictures. That would have been very wonderful to see how extensive the varicose veins were and the wound at presentation with the hyperpigmented skin and the wound at the center of it. And the significant laboratory findings, the PCV, the random blood sugar, the kidney function test, the lipid profile, they are essentially within normal limits. Wound culture yielded heavy growth of Pseudomonas aeruginosa, sensitive to ciprofloxacin, which she had. Color Doppler studies, amongst other things, showed prominent dilated total superficial veins from the mid-thigh down to the dorsum. And the proximal anterior tibial vein is particularly dilated and appears as a tubulocystic mass that you could see on the pictures I had at the proximal part of the right leg. And there's evidence of turbulence at the saphenofemoral junction. And the mid-thigh perforators are more distally suggestive of multi-level valvular incompetence. She also had some degree of peripheral arterial disease that was identified with medial calcifications. So we counseled her and got informed consent to do a mini phlebectomy. And the procedure was well tolerated. We used tumescent anesthesia. The leg was dressed with post-op. She did very well. The leg also was dressed subsequently using Usol and Oni combination. The patient was discharged on the 5th day post-op and continued outpatient dressing. On the 25th day post-op, the patient was reviewed at the outpatient and all presenting symptoms of burning sensations and pain have completely disappeared. And wound had also healed, needing no further dressing. The patient was finally discharged with the following advisory: to avoid prolonged standing and sitting, to continue to wear compression stockings, as often as possible, to raise leg as often as possible when sitting, and also to exercise calf muscle intermittently when sitting. I have the pictures of the patient on the 25th day post-op with the healed wound, the scars from the stab injury, and then 6 months, the picture of the wound site, 6 months, 8 months rather, after that is post-op, with now significant hyperpigmentation, and the patient is still being followed. So chronic leg ulcer is defined as a defect. In fact, that is essentially a presentation. All I have to say about chronic leg ulcer, you already know, for our client, is just as common as it is, or near as common as it is in the Western world. It's not uncommon, yes, common, even though it's significantly overlooked, undetected, not only by the patient, by the health provider, but also by patients. So most times they present late, and that is when they present. That's why, like in this patient presenting with ulcers, prevalence in Nigeria is scarce, reports of being scarce, but just one hospital-based study I found in Western Nigeria, I found a point prevalence of 11%, though the patient number was very few, 48 patients. Chronic leg ulcer, especially venous ulcer, has significant impact on the health system. Yeah, our health system is really not very robust, and it takes a significant toll on patients. Like in this patient, for instance, apart from the finances of dressing the wound, this is a patient whose social life entirely changed. She told me that she will hardly travel outside home because of the logistics of dressing. And common risk factors include age. She falls within the age, it's after 62 years. It's very common after, it increases rather significantly after 60 years of age. Sex, is female. Family history, there's a family history, although her daughter has it. And there's no history of trauma, as we mentioned earlier. The mode of diagnosis essentially is physical examination and ancillary diagnostic findings like color Doppler studies, which we did in this case. The treatment modalities are quite varied, depending on the facility and competence, and then of course the center. For us, we do with traditional graduated compression therapy, and ask patients to avoid prolonged standing, raised leg whenever they're sitting for long. This alone can actually deal with 80% of cases. I mean, no need surgical intervention. But in this case, she needed surgical intervention because compression eventually failed and was not really giving, at least prolonged relief of doing dressing on a daily basis. So the mini phlebectomy, we found it useful in these patients in combination with graduated compression therapy. Of course, in our own case, this very case we did, like I said, it was well tolerated by the patient. As we speak, the patient is doing very fine. Not needing to do any dressing. Wound has healed, and the skin is repigmented, is being repigmented, and patient is happy. We are currently following this patient up to prevent recurrence, which is known to occur in 5 to 10% of cases within 2 years. Hopefully, patient to remain clean without developing any ulcer as we're going to follow. And the references are there. Thank you. That is all I have for the case. Thank you.
Thank you, Dr. Ugoji. Nice case.
Any questions?
Pictures. Thank you so much. Yeah,
thank you, Dr. Oye, for giving me the opportunity to do this presentation.
Thank you. Yeah,
and for all the advocacy work you're doing.
Thank you.
For the vascular surgery, even in Africa and Nigeria.
Thank you. Venous disease is a problem worldwide. And again, when I go to Nigeria, I see patients with venous disease all the time. And it's amazing that, for some reason, the venous disease is a major cause of disability for many persons worldwide, including Africa. So unfortunately, our healthcare system there does not provide enough for the patients that suffer this ailment. We have a lot of options there in the US, but again, it's important to identify venous disease and treat them. Mostly when you have patients come with ulcers, it's always important to know if it's arterial component or venous component, because the treatment option is different. If it's a venous disease, a classic signs that you look for. If it's arterial disease, a classic signs you look for. The ability to have good imaging, be it ultrasound, CT, angiogram, to figure out the difference and then treat the patient accordingly is quite helpful. So thank you, Dr. Ugoji, for that presentation. So
Thank you.
Thank you. Nice job. We're gonna, so we'll go ahead and present one quick case of interest. I'm not sure what's going to be, but we'll see one quick one here. Again, along the line, going along with Dr. Ugoji's presentation, I'll be presenting a case of the use of mechanical thrombectomy devices for options actually for extensive case of DVT, iliofemoral DVT. This is a common problem also in the United States and worldwide. We have lots of options in the US and Europe. We have very few options in Africa. The Percutaneous venous embolectomy options are such. Next. DVT is a major problem, as well stated, and it's common. Over 900,000 people in the US alone suffer from this ailment. It can be common in pregnancy. It can be common in persons with cancer. It can be also common in patients who have trauma. We know about Vincet's triad from medical school. The seriousness of the problem can be debilitating in certain persons. And the question is, what do you do when you have a patient with extensive DVT? Next, please. Let me go back by presenting a few case studies and to highlight one of the issues we have. Our first case is an 81-year-old lady who had the pleasure of treating prior with a lymphoma involving the left thigh region, had surgery several years back, did well, and was seen about 2 days prior to this current presentation. At that time, she was dealing with a recurrent issue with presacral mass that was being prepared for biopsy. And 2 days later, she was admitted to the hospital and was noted to have extensive DVT of the lower extremity on the left with significant amounts of pain. We proceeded to examine her and noticed that her arterial system was fine, the pulses were present, and the DVT was quite extensive on ultrasound, unprovoked. Next. And you could see the initial imaging we did. We first of all put a venous cannula and cannulated the pedal vein, and to ensure patency of the tibial and popliteal femoral veins. We noticed that there was no visualization of the femoral vein, common femoral vein, and iliac vein on the left side. The popliteal and tibial veins were patent on that initial study. What I typically do, if someone has a DVT, and I think it's extensive, I typically will go initially to the foot and do a venogram once after it's been confirmed by ultrasound, of course, just to see what I'm dealing with and my approach for treatment. In this case, the tibial veins were patent, the popliteal vein was patent, the femoral vein was patent, except at the femoral junction, where the common femoral junction, where it was not patent and it was occluded or thrombosed all the way to the common femoral vein on the left. Next, please. So what we did, we tried initially to go through the right groin, cannulate the right groin, and try to go across to treat the left iliac. Unfortunately, it was not possible. You could see the catheter on the right side, could not cannulate it because it's completely occluded. If you go back one picture, previous picture, go back one. So what we did was cannulate the left common femoral direct puncture with a microvenous needle, and we're able to identify the clot burden on the left side. It was actually worse than this. This is a pre-treated area already, but prior to this, there was no flow at all through the left side. And we then passed a glide wire through the clot and manipulated the glide wire with the help of I think with the help of an STR catheter into the vena cava. Once it went to the vena cava, then we proceeded to place in a 6-French sheath, and we proceeded to do a thrombectomy by that. Next, after thrombectomy was performed, we then did some balloon angioplasty of the areas in question that were stenotic. And next, it's a 7-French sheath. Then what you see on the screen right now, on the top screen, was the residual area of high-grade stenosis, which we thought was a culprit lesion. We bring in a concern with the presacral mass. Could this be a case of May-Turner syndrome? And so we proceeded to balloon that area next. After ballooning, go back one. The image below shows that the common femoral area was significantly diseased also, and there was also collateral circulation there. Next, please. So we ballooned and were able to identify from the vena cava to the area of high-risk stenosis, and that could not be treated with balloon angioplasty alone. We initially started with a 12 by 40 millimeter Dorado balloon and elected to put a stent for better improvement of patency. We used a 12 by 80 millimeter stent and followed that with a non-compliant balloon, 16 by 40 millimeter balloon, to furthermore improve that area post stenting. Next. And you could see the 16 by 14 millimeter balloon. It's a non-compliant balloon, and on the right-hand screen, you see the completion venogram, which demonstrated improvement. The stent fully deployed in the vena cava patent. And after this was done, then I was able to cannulate the right, from the right into the left iliac, and then go down to the femoral area where there was some disease, and then we did balloon angioplasty of that area, and we're able to improve flow. Within 48 hours next, the patient did well. She was placed on Lovenox by the oncologist, and she was able to be eventually sent out for the biopsy of the presacral mass. Next. May-Turner syndrome is something we should know about medical students. It's a rare condition. It occurs when the left iliac vein sometimes gets compressed by an overlying right iliac artery, leading to restriction blood flow. Conditions more common in women and then men, and it can result in massive heaviness of the lower extremity, pain, and edema. The DVT obviously is the major problem. PE can sometimes be associated with that. PE is a common problem with patients who have DVT also, so we also have to sometimes do, if they have symptoms of shortness of breath, maybe do a CT to ensure that they don't have pulmonary embolism. Where I rarely put vena cava filters at this time, unless it's a strong reason of extensive PE. Next. Case 2 is another interesting case, 51-year-old female. Well, again, unprovoked DVT. Only difference was she did have metastatic CA, and she'd had some cerebratic surgery done and was planned for additional surgery. So with a unprovoked DVT of the left lower extremity, again, pulses were present, massive edema. In this case, she had no pain. We were able to do the same technique and treat her. Next, please. And we're able, in this case, to treat her. We went from right to left and treated the involved area. Next. And in this particularly, we use the antigen device, which is another mechanical embolectomy device, a realistic agent. We were able to suck the blood clot out. I typically would give some TPA. In this case, I did not. I gave very minimal TPA because of risk factors for potential bleeding. So I think you only use 1 or 2 milligrams of TPA in this case. Typically, I use about 6 millimeters of TPA, and we're able to restore flow. Next. Next. Then you can see the final product here. She looks much better, and see the wire going through the left side into the vena cava, the wire going from the right side into the left side to treat distal areas. Next. She had marked radiological improvement. She was placed on heparin for another 24 hours and placed on Eliquis prior to discharge, and she did quite well. Next patient, please. This is another 25-year-old. You can see the age distribution, 80 plus, another 51, now 25. Female, intractable pain, just had a vaginal delivery, young baby, and she had extensive DVT with intractable pain involving the femoral vein, popliteal vein, tibial veins, completely thrombosis. Next. And in this case, we went trying to go from right to left, but couldn't do it again. You could see the catheter in the middle screen, could not go. You could see on the last screen on the right, the abrupt occlusion on the left common iliac vein. So we stopped the left common femoral vein direct puncture with the microburgess needle, and we're able to put a wire through the left side. And next, once we put a wire through the left side and manipulate the wire into the vena cava, when we did some suction with the angiojet device, we got the blood clot out, balloons next. We did give some TP, of course. You can see the ballooning done in post ballooning, the final picture on the left. We did put a stent in this patient. I think it's a 12 by 40 millimeter stent or 14 by 40 millimeter stent, and post dilated with 16 by 40 millimeter non-compliant balloon. Successful cannulation, and in this case, she has extensive DVT going down the left flank. So we crossed over from the right iliac to left iliac, down the left femoral to all the way to the popliteal. Next. And see the crossover going down next. And we're able to treat all that and restore flow. She did well. Again, heparin and Eliquis was given a discharge. Dr. Saad Akhtar is my medical student who put this presentation together, did a great job with it, and has been part of a presentation for the global conferences, and they do a fine job. Again, the take-home message for this patient is just putting patients on Eliquis or Xarelto with extensive DVT does not treat the whole problem. Yes, they may have some relief, but the valvular damage that occurs when you have blood clots sitting in the veins for an extended period of time can cause these patients debilitating issues, especially if they're young. They can end up disabled and can't go to work, extensive edema of the lower extremities. And so it's better if they are seen early on within the process. In my experience, my clinical experience from 1997, I've been doing TPA-related treatment and aggressive therapy, and I've not had any problems doing that. Patients go in with something, they'll take up a class to do TPA. Sometimes I'll do TPA from the foot IV alone and get some result direct thrombolysis. But if it's something that requires aggressive thrombolytic therapy to be used, as well as using rheolytic agents such as angiojet or any Aspirex or any other device we could use to remove clot, it's better to do that. So the results are usually impressive, and patients do return back to the usual state much sooner, and it's just that also pain-free. So it's it's a technology that we have available in the United States, don't have it available in Africa. So our goal is also to extend this technology to the continent. Thank you.
Thank you. Yeah, that was a great presentation, impressive results. I had a quick question, not necessarily to this one, but I think the prior where you mentioned your atherectomy burrs. Did you have any experience with those blades breaking off when you're doing the atherectomy?
Not yet. I've had experience with wire maybe nearly have been dislodged, but not the device itself breaking off. No.
Yeah, Dr. Rowe, I don't know if you have any comments on that.
No, I haven't heard of that complication. Our institution used to be a very heavy atherectomy center, and we've kind of moved away from it recently. So we're not a big atherectomy usage site right now. But I hadn't heard of the blades breaking off like that.
Yeah, unfortunately, we had two cases. One was actually, we were doing a cardiac case where the coronary atherectomy bore that got broken off, and we had to take it to the operating room. And the other one was for a peripheral vascular disease that was a much bigger rotablator blade. But we had two of those cases. We had done some review of literature at that time, but I just wanted to know if you had any comments on that. But thank you.
Thank you.
For Dr. let me see here. For Dr. Kashyap, how did you manage the cardiac blade that came out? What did you do to retrieve the situation?
Oh, we could not retrieve it. We had to do a bypass for that patient because that patient had an acute coronary syndrome at that time. So we had to take him to the operating room and bypass.
So what did you do with the blade? The blade was left inside, or I still don't understand.
No, we removed it. We removed the blade. Yeah. We opened the coronary. We did the bypass. We removed the blade. So yeah.
I understand. Dr. Rowe, you say your institution is not that big on thrombectomy. I believe that's what you said. So what exactly do you do now?
No, with atherectomy.
Yes, atherectomy. Okay.
Yeah, I changed institutions recently. I went from one to another, and the one I was at, we limited use of atherectomy. We were concerned about the restenosis. And at the institution I'm at now, at UCLA, it was mainly one surgeon that was doing a lot of atherectomies, and that surgeon left. And so the remainder of the faculty, there's not a very high volume user. You know, it's a good tool. I think it's something that you should use, and it works very well in cases. I think it goes back to Dr. Oye's, statement he made about 3 times today for us. It's patient selection. So, the technology is there and it works. It's just patient selection and when you decide to use it. So my experience with it is low. So I don't want to make a just, supported comment.
But how do you treat your cases though? What do you do for this big thrombosis?
For the lower extremities, I like just angioplasty. I'm not a big stinter into the tibial regions. I had a partner that was, but I like long segment angioplasty the best. You may have to go antegrade down through the plaque or retrograde up, but at this point, I really like the angioplasty, and unfortunately, there's no drug-coated angioplasties for the tibials at this point, from the balloons not being that small and having a weird trial result from prior. So right now I'm just using angioplasty. And then I still was always a fan of, if need be, bypass. So I'd use that. And then the other component, if it's acute clot, I think suction embolectomy, suction catheters work very well as well, and aren't as dramatic as the atherectomies, but I think the suction catheters work very well.
Good, thank you.
Dr. Rowe, that's very nice. I have similar thoughts. When I came to West Virginia in 1997 from Arizona with Dr. Dietrich, I could stand anything I walked. Then in that area of West Virginia was the northern part of West Virginia. Then I moved 8 years later to the southern part of West Virginia, and my standard results were not as good in the SFA. So I moved away from stenting the SFA completely. I do angioplasty. And then in 2006, 7, I picked up the atherectomy component, and I did a fair amount of atherectomy. I'm selective for atherectomy, and but again, I think from the vascular standpoint, we as vascular surgeons have the endovascular toolbox and open toolbox. Being able to identify which tool to use and when to use the tool is what for the best result is what makes a big difference. So yeah, lately my young doctor is going to present another case which I think would see, agree with you, would see that doing a bypass is great. We'd love to do bypasses, but when you can avoid a bypass, it's obviously even better, and delay the bypass for a later day because of our patient population non-compliant, they're heavy smokers. You do a bypass, they come back, clotted, then you have to worry about doing a redo a bypass and all that. So that being said, I'll get my next speaker, student Dr. Bakr Aruna, to give us an interesting case that you'll find exciting.
Thank you, Dr. Oye. My name is Bakr Aruna. I will be presenting on the topic of peripheral arterial disease treatment with shockwave intravascular lithotripsy. Here is the agenda: introduction, background, shockwave intravascular lithotripsy, case and conclusion. I am a third-year medical student, and I'm currently doing my surgery rotation with Dr. Oye. So a little bit of background: peripheral arterial disease in the legs or lower extremities is the narrowing or blockage of vessels that carry blood from the heart to the legs. It is primarily caused by the buildup of fatty plaque in arteries. Peripheral arterial disease can happen in any blood vessel, but it's more common in the legs than in the arms. Statistics show that over 12 million people are affected by peripheral arterial disease in the US, and it is estimated that the incidence of peripheral arterial disease in the US is 200,000 per year. Over 200 million people are affected worldwide, with prevalence increasing with age. The risk of peripheral arterial disease is higher among smokers, diabetics, hypertensive, and in people with high cholesterol. Here I've listed a list of complications of peripheral arterial disease: critical limb ischemia, ulceration, amputation, gangrene, decreased mobility. Here I've also listed some signs of acute limb ischemia: pain, pallor, paresthesia, pulselessness, and paralysis. Now, the treatments for peripheral arterial disease vary based on the severity of the disease. So you can have non-surgical treatments or surgical. Today, I will primarily focus my attention on the shockwave intravascular lithotripsy. Now, here is the device that is used, for shockwave intravascular lithotripsy. Shockwave intravascular lithotripsy is a minimally invasive procedure that uses acoustic pressure waves to break up calcified plaque and opens up the artery. This technique has been shown to have several benefits over traditional methods of treatment, including increased safety, improved efficacy, reduced vessel wall damage, and reduced need for additional procedures. Here is the machine, and basically it consists of a generator. Give me a second. It consists of a generator, a connection cable, and a catheter. And there are several variants of the catheter depending on what site you want to treat. So there is what you call a C3 catheter that is used in coronary vessels. The M5 catheter is used in peripheral vessels like the popliteal arteries, the femoral artery. And you can also use an S4 catheter, which can be used in the tibial artery. Here's a case of a 66-year-old Black male with a peripheral vascular disease, status post right femoral popliteal bypass in 2018. Has a coronary artery status post CABG, cardiomyopathy status post ICD placement, also has hypertension, hyperlipidemia. So the presenting symptom is that he had a painful right leg, severe right leg pain, and the examination showed that the right foot was cold and had weak pulse. CT angiograph showed with runoff showed right fempop thrombotic occlusion and reconstitution of flow in popliteal artery above the knee. So the diagnosis was made, and the diagnosis was recurrent right leg ischemia secondary to occluded right fempop bypass. So the plan was to obtain a cardiology clearance, and after that was obtained, we proceeded to perform the procedure. So the procedure included aortobifomeral arteriogram, selective right leg arteriogram, cannulation of the right common femoral artery, crossover from left to right to enter occluded right femoral artery, and the native artery was cannulated with the passage of an advantage guide wire and ultimately using a 0.035 guide wire. Angioplasty with a 5mm by 40mm shockwave balloon was used, and angioplasty with 18 LP balloon also was used. And we did a completion arteriogram to visualize, the effects of the treatment. Here, the left diagram here, the left image here shows the bypass, occluded bypass. This shows the profundal artery, and here is supposed to be, where the femoral popliteal bypass, begins. And here is, I believe, the superficial femoral artery, and here is where the bypass was supposed to connect to the popliteal artery. So we proceeded to cannulate the common femoral artery by using a microvenous needle. And here shows how we navigated from artery into the iliac and crossed over using a Navicross wire, to the right side, right femoral artery. This other image shows how the occlusion of the popliteal artery here. And here, the next image shows the introduction of the catheter. And the next image here, shows a focused treatment of the occlusion. And also, we proceeded to recanalize the femoral artery. And here shows us starting with the distal superficial femoral artery, going all the way to the common femoral artery. So here shows the post-operation video showing patient artery.
Patient has allergies on latex. Patient has given antibiotics prior to procedure.
So the case takeaway is that lithotripsy with shockwave balloon eliminated the need for a redo femoral popliteal bypass. The procedure was percutaneously performed with only a 6 French sheet. Post-operation showed presence of a right foot pulse and warmth, and the patient was discharged early due to quicker recovery time because the procedure itself is minimally invasive. Thank you.
Thank you. Nice job. Yeah, that was an excellent presentation by Dr. Aruna, and that also shows us again the benefits of minimally invasive endovascular intervention, where open surgery was averted. Patients came in with bad heart, AICD, cardiac workup done, and real bad heart. And the redo femoral bypass in this case would be fraught with some issues. Not only with the pain, possibility of recurrent thrombosis down the road, and the ability for us to go through its native artery, which we could not do in the past, but we're able to do now with this technology, restored flow, without having to even put a stent in this guy. So that was really, really cool. And it was a great result for him. And again, I always preach the endovascular toolbox. You have a lot of tools. You got to figure out what to use, when to use, and how to use it. And so that was a great case. Thank you very much. Any questions on that?
Well, how old is this technology that you've been using for this kind of situation?
The technology has been out probably about 2 or 3 years, but we just adopted this technology at the hospital here just recently within the past. I personally started using it within the past 3 weeks. But the technology has been out already. I tend to make cost an issue for my patients. I try to decrease cost. So if I can get away doing balloon angioplasty alone and have a good flow or good result, I do that. And if I think that added stenting might help the patient better, I'll do it. But I try to, in the back of my mind, I'm always, wanting to ensure that we don't use things just because they're available. We have to use things because it's the best thing for the patient. And again, that's a big problem in American healthcare system. We tend to be quite wasteful. And so it's a problem. And again, as we navigate the healthcare system that we do have now, as we look for ways to improve the healthcare system globally, we have to kind of keep that cost is a major issue. We have persons in Africa that cannot afford to have what we just did on this patient. It's just not there. So how can we treat those patients? We'll treat them with standard balloon angioplasty that we do, which is a lot cheaper. But if the technology or they can afford it and we can get that available in medical undisturbed areas, we want to make it available. So at least have all persons have equal playing ground or field. Yeah.
Which of the hospital has this? Is it Raleigh General or ARH?
They both have it. As a matter of fact, this week alone, I did several of these. This past week, I did about 3 or 4 of these this past week. I had a very interesting case. I don't know if we're going to present that today, but maybe next time on other patients. But yeah, both hospitals have them.
Good.
Yeah. Yeah. So again, this has been a very interesting. Any further questions before we wrap this up?
Well, let me ask Dr. Ugoji a simple question. Dr. Ugoji, how did you get, knowing all the difficulty in getting any materials, any healthcare materials in Nigeria, what kind of compression did you use and how did you get it?
Okay, we have compression stockings that are sold in medical shops, medical equipment shops.
Got it.
Yeah, we have compression stockings.
Good. So you don't have any problem getting it. Good, thank you.
Yeah.
Do you have room for one more question, Dr. Oye?
Sure, go ahead.
Okay, good. Well, now that I have 2 very brilliant vascular surgeons in front of me, I want to ask you this question, which is not really related, but is kind of related. I chair the trauma center in Raleigh General, and yesterday we were discussing how, we have a lot of patients that come in with trauma and bleeding, there's panic bleed and this and that. And the question is, why don't we do embolization for this? I mean, nobody's doing it in Raleigh General. And we know the radiologists are very short-staffed and they're not interested in doing that, the interventional radiologists. So the question came, they want me to talk to you guys, the three big vascular surgeons in Raleigh General. Is that something you may want to try to do embolization for us? Because right now, there's so many things we could do instead of removing the spleen or removing a portion of the liver because they're bleeding, and it's just not the right thing to do when we have embolization. That could be a lot easy. With you guys being endovascular surgeons, is that something you may want to consider if we push it?
Absolutely, yeah. I mean, I've done embolization before, and it's quite easy. Yeah, so we can certainly talk about it and look at setting up a program. That's not a problem. Yeah.
Good. I appreciate that. We'll push it down the road, but that's something that came up yesterday, and I didn't know to say, oh, you guys, I know you guys are very, very busy, the three of you, and radiologists are not interested in doing it, and we definitely need it.
Yeah, no problem. I think
okay, thank you.
Interested.
Yeah.
Any further questions from the panel?
Very good conference. Thank you.
From the audience before we
I enjoyed it a lot.
Thank you. Dr. Any comments from you before we?
No, thank you for inviting me and organizing it, and really enjoyed it. So I'll be hoping to come back and have some more cases to present to share with everyone.
Yeah, thank you. Thank you so much.
Same here.
Thank you, Dr. Ugoji. Appreciate it. So on behalf of the speakers today and medical students, the future generation of speakers, I have one more comment from Dr. Singh, our respected general surgeon, vascular surgeon here. Dr. Singh.
Dr. Sangodeyi was talking about embolizing the splenic artery. We had a patient, I think, in Raleigh General Hospital, and they wanted to embolize rather than operate and take the spleen out. I think this was a high-risk patient. And there was a question that Dr. Oye and Dr. White and Dr. Ryan will be interested to embolize the artery without taking the spleen surgery and taking the spleen out. That's what the reason why Dr. Sangodeyi was talking about this. Can you embolize the spleen artery?
Yes, I can. Yes. Yeah. Yes, we can. Yeah, that's no problem. We can do. We embolize the. Yeah, it's not a big deal. We embolize the internal iliac arteries and other arteries.
That's very good. That was the reason I think we were discussing that yesterday.
Yeah, no problem. We can do that. Yeah,
okay.
We'll just have to start the promote.
Okay, thank you. Appreciate it very much. Thank you.
So on behalf of the organization, the Raleigh General Hospital, which gave us the opportunity to host this program today, I'd like to say thank you for participating in the program. This is going to be hopefully a quarterly program. Our next scheduled time will be sometime in April. We'll make the announcements a lot sooner. And again, in October of this year, we have the endovascular conference for Africa every October. This will be the 6th annual conference. And we look forward to seeing you, or if you have any interesting cases to present similar to this, we'll welcome all that. The whole idea is to ensure a healthy relationship between practitioners in the US, Europe, and Africa and other continents, so we can continue to share and learn from one another. So it's been an exciting conference, and I thank you all for taking your time out on this busy Saturday to be with us. Dr. Kashyap, Dr. Ugoji, Dr. Rowe, Dr. Sangodeyi, and all the young doctors that presented, Dr. Sunanda, Dr. Rhoades, and Dr. Bakr Runa. Thank you so much, and we hope to see you.
Thank you.
Thank you. Have a great day.
Thank you for getting me on.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye-bye.
Bye.